You know, taking a patient's vital signs is one of the most fundamental skills in all of medicine. But doing it with real precision, that's an art. So today, we're going to walk through the exact clinical protocols, step by step. We're going to focus on all those little details that make sure you not only get it right, but that you really understand why you're doing each step. By the end of this, you're going to feel totally confident doing this assessment.
All right, so here's our game plan. We're going to follow the exact flow you would in a clinical setting. We'll kick things off with the crucial prep work, then move through each measurement one by one, and wrap it all up with assessing consciousness and getting that documentation perfect. So let's dive in.
Okay, before we even think about touching any equipment, we start with a simple framework called Weber. You should think of this as your mandatory pre-flight check. And trust me, this isn't just about being polite. It's about making sure you have a safe, professional, and patient-focused environment right from the get-go.
So what on earth does WIPER stand for? Well, every single letter is a step you just can't skip. W is for wash your hands, simple but critical. I is for introduce yourself, who you are and what your role is. The second I is to identify your patient. You have to confirm you've got the right person. P is for permission. You've got to get their consent before you start. E is for expose, meaning you only uncover what you need to, like their arm for a blood pressure reading, while making sure to maintain their dignity. And finally, R is to reposition the patient, making sure they're sitting comfortably and at rest.
You know, being prepared is half the battle. So before you even approach the patient, get your kit together. You're going to need your PPE, maybe some gloves, your alcohol gel, of course. A watch that has a second hand is absolutely essential. A stethoscope, your blood pressure cuff, that's the sphygmomanometer. An oxygen saturation probe, also called a pulse oximeter, a thermometer, and maybe most importantly, your observation sheet so you have somewhere to write all this down.
All right, let's get into our first set of actual measurements. The pulse, breathing rate, and oxygen levels. These three together give us a fantastic, immediate snapshot of how the patient's heart and lungs are working.
First up, the radial pulse. You want to find the radial artery, which is on the thumb side of the wrist. Now, use the pads of your index and middle fingers. They're the most sensitive. And here is a classic pro tip. Never ever use your own thumb. Why? Because your thumb has its own strong pulse, and you could very easily end up counting your own heartbeat instead of theirs. So count the beats for a solid 30 seconds, then just double that number to get the beats per minute. Now, if the pulse feels irregular at all, you must count for a full 60 seconds to get an accurate number. No shortcuts.
Now, this next slide. This highlights a really subtle but incredibly important technique. It's one of those little details that really separates an experienced clinician from a novice, and it's all about getting your next measurement right.
Here's the secret. If a patient knows you're watching them breathe, they'll almost always change how they're breathing, without even meaning to. It becomes unnatural and your reading is useless. So here's what you do. After you've counted their pulse, just leave your fingers on their wrist, acting like you're still feeling it, but really you're shifting your eyes to their chest. Watch it rise and fall. Count each breath for another 30 seconds and then multiply by 2. And just like with the pulse, if something seems off, take the time to count for a full minute.
Next up is oxygen saturation. This one's usually pretty straightforward. You just pop the pulse oximeter on the patient's finger. The key here is patience. Let the number settle down and stabilize before you write it down. And here's a super common pitfall you've got to avoid: nail polish. Or even worse, false nails. They can physically block the little light sensor in the probe, which means you'll get a wonky reading or no reading at all. So always try to find a clean finger if you can.
Okay, deep breath. Now we're moving on to what is often the trickiest vital sign to get right manually: blood pressure. Getting an accurate reading is truly an art, and it demands you be precise at every single step. So let's break down how to do it right, and just as important, how to do it safely.
Hold on. Before you even reach for that cuff, you have to stop and ask a couple of really critical questions. This isn't just about getting an accurate number anymore. This is about preventing actual harm to your patient. So let's talk about that. Okay, there are some absolute no-go situations for choosing an arm. You never use an arm that has an AV fistula. That's a special vessel for dialysis. The pressure from the cuff can literally destroy it. Also, avoid an arm on the same side as a past mastectomy or lymph node removal. The lymphatic system there is compromised, and you could cause a painful chronic swelling called lymphedema. And then, of course, the obvious ones. Don't use an arm with a fresh injury or an IV line in it.
The patient's condition right now is just as important as your technique. To get a true reading, they need to be rested, ideally for about 5 minutes. And you have to ask them, hey, have you had any coffee, done any exercise, or had a cigarette in the last half hour? Because all three of those things can temporarily spike their blood pressure and give you a false high reading.
Cuff size is everything.
Seriously, using the wrong size is one of the most common mistakes out there. If it's too small, your reading will be falsely high. If it's too big, it'll be falsely low. The rule of thumb is that the inflatable part inside the cuff should wrap about 80% of the way around their arm. Once you've got the right size, feel for the brachial artery on the inside of the arm, and then line up the cuff's artery marker right over it, about an inch above the bend of their elbow.
Now, this next step is a game changer for both your accuracy and your patient's comfort. We're going to estimate the systolic pressure first. This prevents you from just blindly pumping the cuff up way too high. So put your fingers back on the radial pulse and start inflating the cuff. The exact moment you feel that pulse disappear, look at the dial. That number is your estimated systolic pressure. Remember it, then deflate the cuff completely and give their arm a second.
All right, time for the main event. Put your stethoscope over that brachial artery. Now inflate the cuff again, but this time go to about 20 or 30 points above the number you just estimated. Then slowly, steadily let the air out. That very first clear thump-thump sound you hear, that's it. That's the systolic pressure. Keep listening as the sound gets fainter, and the exact point where it vanishes completely, that's your diastolic pressure.
So let's just lock in these terms so they make perfect sense. Systolic, the top number, that's the pressure when the heart is actively squeezing. Diastolic, the bottom number, is the background pressure when the heart is relaxing between beats. And those little tapping sounds you were listening for, they have a fancy name, Korotkoff sounds. Fun fact, it's not actually your heartbeat, it's the sound of blood starting to flow turbulently through the squished artery again. Pretty cool, right?
We are on the home stretch now. We've collected all of our numbers, and now it's time for a super quick check of the patient's level of consciousness, and, maybe most importantly, writing it all down correctly.
So the AVPU scale is a fantastic, simple tool for this. Think of it as a quick checklist. Is the patient A for awake and alert, or do they only respond to a V for vocal command? If not, do they respond to P for a pain stimulus? And if there's no response to anything, they're U for unresponsive. Easy as that.
Look, you can do all of this perfectly, but if you don't document it, it's like it never happened. You have to meticulously record every single vital sign on that observation sheet. Then, from those numbers, you'll calculate something called an early warning score, or EWS. This score is so important because it takes the guesswork out of things. It tells you objectively how sick a patient might be and links directly to a protocol that tells you exactly what to do next.
So, when all is said and done, what's the big takeaway here? It's that these numbers are so much more than just data points on a chart. Every single one is a clue. And when you put them all together, they start to tell the opening chapter of your patient's story in this exact moment. Mastering this process means you can read that story accurately and, most importantly, act on it to write a better next chapter.